A broken bone mends and an infection clears, but physical trauma leaves a lasting residual effect. Long after the acute phase ends, a condition remains. In ICD-10-CM, this is a sequela. This timeline illustrates the transition. The spike represents the acute event, which eventually terminates and drops to the baseline. The highlighted line that follows is the residual phase, the lasting effect of that prior condition. Guideline B.10 specifies that sequela coding has no time limit. Whether the residual effect appears immediately or 20 years after the injury, the coding requirement remains the same. This lack of an expiration date means a coder may report a scar that formed during the healing process, or a complication that only becomes clinically significant decades later. Accurate sequela coding requires documenting this history while prioritizing the patient's current clinical status. This creates a specific operational challenge. How do you translate a patient's chronological history into the nonlinear hierarchy of ICD-10? It is a common instinct to report the historical cause, the original injury or illness, as the primary code because it started the chain of events. However, the ICD-10-CM sequencing rules reverse this order. While the cause comes first in time, the effect must come first on the claim. Reversing this sequence leads to errors in the medical record. If the cause is sequenced first, the billing system may flag the claim as a sequencing error or an improper reporting of an acute event. To code these cases correctly, you must apply the inverted hierarchy defined by Guideline B.10. Reporting a sequela typically requires two codes. A single code rarely describes both the patient's current condition and the historical event that caused it. We organize the sequencing using a simple rule: current first, cause last. The primary code represents the nature of the sequela. This tells the system exactly what the patient is suffering from at this moment. The second code is the sequela code itself. This identifies the original illness or injury that led to the current problem. By following the current first, cause last logic, the coding accurately reflects the clinical reality of the patient. This dualism ensures the payer and the health system understand that while the past caused the condition, the present manifestation is what requires treatment today. Let's apply this to 3 scenarios, starting with a patient who has a scar from a severe, fully healed burn. The scar is what the patient has now, so it is sequenced first. The historical burn is sequenced second to provide the cause of that scar. In a case of a deviated septum resulting from an old nasal fracture, the logic remains the same. The deviated septum, the current manifestation, is the primary code, followed by the nasal fracture sequela code. Finally, consider a patient with infertility caused by a previous severe infection. The infertility is sequenced primary, with the historical infection assigned to the secondary position. Across every anatomical system, the rule is consistent. The residual manifestation is always the primary code. One of the most common errors in sequela reporting is the use of the original acute condition code. You must not assign the code for the original acute illness or injury once that acute phase has ended. Assigning an acute code suggests the patient is currently in the crisis phase of a trauma, which is clinically inaccurate for a sequela case. This misreporting skews hospital data, making it appear that there are more active trauma cases than there actually are. Payer systems are designed to detect these temporal conflicts. If an acute code is reported alongside a sequela code, the claim will likely be denied because the two states cannot exist at the same time. Correctly omitting the acute code is essential for maintaining a clean and accurate medical record. While the two-code rule is the standard, there are specific exceptions found in the tabular list. Some entries use expanded combination codes. In these cases, a single code absorbs both the manifestation and the cause. Because these combination codes are more specific, the standard two-code requirement becomes unnecessary. In other instances, the tabular list may provide specific instructions that change the sequencing order entirely, requiring the manifestation to follow the sequela code. As a coder, you must remember that specific tabular list instructions always take precedence over general guidelines. Use the standard sequencing as your default, but always verify your code in the tabular list. To ensure accuracy, you can apply a simple 3-step checklist to every sequela claim. Step 1. Identify the residual condition the patient is presenting with today. This is your primary code. Step 2. Identify the historical cause. This is your secondary code. Step 3. Confirm that the acute condition code is not on the claim. Following this checklist ensures that every chart meets the requirements of Guideline B.10. Sequela coding allows the healthcare system to track the long-term outcomes of injuries and illnesses. Understanding how to prioritize the present manifestation over the historical cause is a fundamental skill for professional coding. By applying these sequencing rules consistently, you ensure higher data integrity and reduce the likelihood of claim denials. Always lead with what the patient has now, follow with what caused it in the past, and maintain the clinical truth of the medical record.